This lecture is going to focus on some of the treatment options that exist for either motion sickness or vertigo, as many of the receptors and associated pharmacologic targets are more or less the same. So this is the vomiting center, and essentially it involves multiple pathways that can be pharmacologically targeted or manipulated to either treat vertigo and or motion sickness. All right, so from a pharmacologic standpoint, we can target histamine receptors, dopamine receptors, particularly D2, serotonin receptors, particularly the 5-HT subtype 3, and the muscarinic receptors, the M1 receptors, which of course bind to acetylcholine. There are five neurotransmitter systems that can kind of govern the vomiting reflex. Four of these are hosted here, and of course there's neurokinin 1. I don't think there's any drugs yet to neurokinin 1, which is why I left it out. But a lot of these receptors are both located in the brainstem, in the vestibular system, as well as the chemoreceptor trigger zone. Always remember that the chemoreceptor trigger zone, sometimes called the CTZ, is the area basically outside of the blood-brain barrier. It's also associated with the area postrema, sometimes affectionately referred to as the BARF center. And so all of these receptors are pretty much associated with this region, the BARF center, the vomiting center. With a name like that, you can't forget it. And for this is also from like a evolutionary standpoint, as our caveman and cavewoman ancestors kind of walked around the jungle and ate different berries and fruits and so forth. Things that were poisonous, of course, stimulated the vomiting center, and these plants and so forth were not ingested. So it does serve as a kind of a protective or adaptation type of response to the outside environment. But nonetheless, from a pharmacologic standpoint, we definitely want to target it, at least if we want to treat motion sickness. And so from a pharmacologic standpoint, we've got three main kind of groups of drugs that are really good at reducing motion sickness. The H1 blockers, dimenhydrinate, which is the generic for the brand name Dramamine. There's also some overlap here. Dimenhydrinate also has some antimuscarinic effects. But a classic H1 blocker includes dimenhydrinate, meclizine, and promethazine. Your classic muscarinic M1 blockers include scopolamine, which is usually applied as a patch, so topically. Meclizine is also a M1 blocker, as is promethazine. And then your classic kind of D2 blockers include the prototype promethazine. So obviously there's quite a bit of overlap between these drugs, but the overall goal here is to reduce nausea and vomiting, which is associated with motion sickness. And so the overall, the most common side effect that we can see is obviously going to be drowsiness, and that's the most often cited and most often complained about side effect. You will reduce motion sickness, but the patient will be sleepy. Dimenhydrinate, also known as Dramamine, is actually structurally related to diphenhydramine, which is Benadryl, and it's indicated for motion sickness, vertigo, or just in general nausea and vomiting. Interestingly, it is a CYP2D6 substrate and inhibitor, and there's a very well-established and direct effect on codeine metabolism. So patients that are taking this drug for whatever reason are going to have a hard time biotransforming codeine for adequate pain control. This, of course, would obviously come into play post-op, where there's post-op nausea and vomiting. This drug would actually not be indicated for that because I'm assuming the patient will be on some type of pain management, which would imply the use of some codeine derivative. Meclizine, we said, is an antihistamine, but it's also an antiemetic. The brand name here is Bonine. I'm putting the brand names on here because these are all over the counter, and most people know them by their brand name. But of course, you'll be tested on the generic. Mechanistically, meclizine is a non-selective H1 antagonist with a little bit of anti-muscarinic effects. And of course, you can see the side effect profile, which would match that. So drowsiness, dry mouth, and fatigue. The drowsiness, definitely from the H1 antagonism, and then the other two, most likely from antimuscarinic effects. Meclizine is indicated for inner ear infections, also vertigo, motion sickness, and you can use it for the nausea associated with pregnancy. You do, however, want to avoid or use this drug with caution in both elderly patients as well as children. And a lot of it comes from some of the antimuscarinic effects and potentially some of the other effects that we'll talk about when we examine some of the more commonly associated diseases of the elderly. Scopolamine is synthesized from Solanaceae plant sources, so it's related to atropine. It does bind to muscarinic receptors as far as we know. We think M1, but it actually hasn't been determined yet. And obviously this drug is going to compete with acetylcholine at these muscarinic receptors. Typically you see scopolamine used as a patch, a transdermal patch, to reduce motion sickness or seasickness. And typically patients, you can see them at every harbor and every cruise ship. If you've ever gone on vacation, they're quite common. Most people, they're like a small brown patch about the size of a dime, maybe a quarter, and they usually put them under the ear. This drug can be liquefied and then injected intramuscularly to manage and kind of control some of the post-operational nausea that some patients can complain about. Side effects include drowsiness and fatigue, of course, dry mouth. These are all the antimuscarinic effects. Tachycardia, so this is direct antagonism of the M2 receptor, of course, when given systemically. Blurred vision, all these kind of more systemic side effects come from higher doses of intramuscular injections that you'd encounter for post-op. When used as a seasickness patch transdermally, the side effects are almost negligible. Again, which is why this drug would be over the counter. Promethazine officially is a D2 receptor antagonist, but it also has anti-muscarinic and antihistamine blocking effects. Same side effects with the added side effect here of movement disorder, which we'll talk about shortly, known as tardive dyskinesia. And that comes from direct antagonism of the D2 receptors. You can also see some respiratory depression. I'm not really sure which receptor subtype that's responsible for, but it definitely does happen sometimes with promethazine. And again, the indications include inner ear infections, vertigo, and motion sickness as well. And so just to kind of summarize, if you want to look at the drugs for vertigo, again, the goal here is to reduce nausea and vomiting. But again, the main side effect is going to be drowsiness. And so we can use histamine H1 blockers, M1 or muscarinic blockers, as well as dopamine D2 blockers. There's a few more drugs that are indicated to block dopamine outside of promethazine, prochlorperazine, and metoclopramide. And these will be covered in later blocks because we actually use them for other things besides vertigo. And so the other thing I wanted to kind of point out is that when we talk about the drowsiness, it's really kind of coming from the degree of H1 antagonism. So meclizine is on one end of the spectrum, on the lowest end of the spectrum, and then diphenhydramine, which is on the other end of the spectrum, has the highest degree of drowsiness associated with it. And any of you have ever taken a Benadryl for whatever reason, it pretty much knocks everyone out almost instantaneously. Meclizine is not as strong, but both of them do kind of antagonize H1 effects, and so it's really a good choice to kind of go after vertigo and or motion sickness. All right, so these are the drugs for these conditions. They all have a kind of a similar mechanism of action and similar side effect profile, and these are these uses. Thank you.